Yeah, yes, sir.
Okay.
A very good morning to all here. Good morning is not just a word, it's an action and a belief to live the entire day well. A very good morning to one and all. It's a glad welcome we bring to you this morning, filled with the desire, hopes, and dreams we all share. Small cheer and great welcome makes a merry fest, says William Shakespeare. On behalf of our Dean Sir, teaching and non-teaching staffs of School of Allied Health Sciences, Vinayaka Missions Research Foundation, Salem, we welcome you all for the International E-Conference on Basic Medical Sciences, June 2020. I'm glad to welcome our esteemed speakers of the day, Dr. Abraham R.J. Nayakanti, Dr. Satyanarayana Murthy, Dr. Pratipa. I also welcome to all the faculties and students of various institutions who have joined here for today for this conference. And now invite our Dean, Dr. B. Sendil Kumar, to deliver the welcome address.
Thank you, Swati.
Thank you,
It's
sir.
my pleasure to extend my warm welcome to you all for the first time ever International E-Conference on Basic Medical Sciences, BMedCon' 2020. Your presence, even though virtual, makes us very happy. I would like to start with a quote by Albert Einstein. Never regard study as a duty, but as an invaluable opportunity to learn to know the liberating influence of beauty in the real of spirit for your own personal joy and to the profit of the community to which your later works belong. So we are proud to create this opportunity to all the young minds gathered here. Basic medical sciences is important to the allied health sciences curriculum because it is a fundamental discipline for learning other foundational sciences. It teaches how scientific reasoning can be applied to clinical decision making and provides a framework for solving clinical problems that requires insights. This knowledge leads to better ways to predict, prevent, diagnose, and treat disease. Now, more than ever, medical educators at all levels are tasked with delivering foundational concept and content necessary for the next generation of allied professionals who incorporate evidence-based medicine into their clinical practice and research. Integrating basic science education with its clinical application from the initial stages of learning is thought to improve retention of information and facilitate the transfer of knowledge to the clinical setting. Israel Moreover, who is an inspirational writer, blogger, and speaker and youth icon, says that we are no longer in the dispensation of age and experience. We are in the era of knowledge and information. Information leads to a true leader, and true leader leads to others. Hence, we, School of Allied Sciences, has arranged for this conference to pass on the information and knowledge needed for you to become leaders of the futures in your chosen field. We are deeply honored to welcome our speaker today, Dr. Abraham, Anatomy Associate Professor, University of Avalon, University of School of Medicine, Curacoa. Dear participant, I welcome you all once again and wishing you all happy learning. Thank you.
Thank you very much, sir. First day we have sessions with the anatomy. Our first speaker is Dr. Abraham R.J. Nayakanti, Associate Professor, Avalon University of School of Medicine, Santarosaweg, Willemedsted, Curacoa. He completed his MSc in SVIMS Tirupati. He completed his Ph.D. in Vinayaka Missions Research Foundation, Salem, and he was working as lecturer in Vinayaka Missions College for 4 years. Then he went to Avalon University. Now he is working as an associate professor for human structure and function, covering the curricular content of gross anatomy, lab, histology lecture and lab, and development anatomy. He has good knowledge in integration with horizontal, vertical, and clinical integration, orientation classroom, and laboratory teachings. He has approximately 3.5 years of teaching experience in India. He has been working as a faculty member of the school for more than 7 semesters and 2 years. His teaching methods, both in classroom and laboratories, he has presented and participated in various conferences held in US, Switzerland, and India. Among his many accomplishments, he completed a certificate program from the Associate for Medical Education in Europe in medical education. He has participated in all the workshops conducted by Avalon University's executive on Bloom's taxonomy, Miller's pyramid, formative and summative assessment. The outcome of the workshop was able to set learning objectives and design the course curriculum and implement formative and summative assessments in the course. Now, we welcome Dr. Abraham R.J. Nayak. Thank you very much for accepting our invite, sir.
Most welcome, ma'am.
Yes, sir. Now you can share your screen and you can proceed your first session, sir.
Very much, ma'am. Thank you, Dr. Sindil,
Thank
sir,
you, sir.
for your kind words, and thank you, ma'am, for your kind words too. Yeah, now I would like to start my session for today. Actually, I was thinking on what topic is good for the students of different basic medical sciences that will be helpful. Am I audible good, ma'am? My sound is good?
Yes, sir. Yes, sir.
Thank you. Yeah. And then when I was thinking, then the thought of congenital heart diseases made me feel that it is important for the students to know because heart is a vital organ. Heart is an important structure. It is essential for everyone. It is a life-saving structure. As you all know, if one's heart stops functioning, that indicates that the individual is almost ready to leave us. So I thought, let me take the heart conditions. So when I was thinking on heart conditions, I felt that to understand various embryological reasoning and also to understand the current epidemiological perspective of these congenital heart diseases would help us to have an idea and understanding of the current scenario. Okay, before I would like to introduce the congenital heart diseases, I would like to just give you a brief outline of what a heart is. As you all know, there are the heart four chambers: right atrium, left atrium, right ventricle, and left ventricle. And the right atrium and left atrium are partitioned by a wall, interatrial septum, whereas the left atrium, left ventricle, and right ventricle are partitioned by a wall, which is known as interventricular septum. The entry or the right atrium is partitioned from the right ventricle by a valve, which is nothing but the tricuspid valve, which contains three cusps. And onto the left side, we see the left atrium is connected to the left ventricle through a bicuspid valve. And we all know that the right atrium contains the blood entering from superior vena cava, inferior vena cava, and the coronary blood vessels. Whereas the blood that is entering into the right atrium is drained through the tricuspid valve into the right ventricle. And once it reaches the right ventricle, the blood flows the pulmonary trunk using a tricuspid valve.
Sorry, sir. Dr. Abraham, sir. Sorry for the interruption, sir. Your slides are not moving in the presentation, sir.
Yeah, ma'am. I'm just giving an introduction about the heart. Yeah.
Okay. Okay, sir.
Yeah.
இதுக்கு முன்னாடி லூஸ் அப்போ ஃபர்ஸ்ட் மேட்ச்ல காலையில இருந்து
This is the congenital heart diseases. So we would like to see what are the structures that are involved in the heart. Okay. So I was just giving you a brief review of like from the right ventricle, from the left ventricle, the blood leaves into the aorta through the tricuspid valves, and then the blood enters into the aorta, like ascending aorta, arch of aorta, and then descending aorta, and from there through into the all the trunks, into all the blood vessels that are supplying the whole body. So that is the vasculature, that are the blood vessels that occur. Now I would like to start with an animation video which helps you to understand a better view of so that there won't be any disturbance. Yeah, I just have interrupted with the presentation, and I would like to share the video to you. You can try to understand how our development of heart occurs. As I was mentioning earlier, like we have right atrium, left atrium, and right ventricle and left ventricle. If you look at the wall, the right atrial wall will be thin, whereas the ventricular walls generally will be thicker. And when you compare right ventricular wall with the left ventricular wall, the right ventricular wall will be thinner compared to the left ventricular wall. So generally, these are the endocardial cushions that comes in close, resulting in formation of the bicuspid valves. And if you observe here in this particular section, so this is septum primum, which is forming an initial part of your partition between right atrium and left atrium. And this is a foramen primum, which will get obliterated with the complete fusion of the septum primum with the endocardial cushions. And if you observe here, so the septum primum gets closed, and then there will be apoptosis taking place within the membrane, and this results in formation of a foramen here. And this foramen, we call it as foramen secundum. And this foramen secundum is further overlapped by a septum secundum, which is arising from the right ventricle. So that leads to covering of this second foramen secundum, resulting in formation of an oval foramen. And this oval foramen, we call it as foramen ovale. So if you observe within the interatrial septum, we found three foramen named structures. One is foramen primum, second one is foramen secundum, and third one, after formation of this septum secundum, it is foramen ovale. So these are the three foramens generally you see in interatrial septum. Now, if you come to the ventricular part, this is a muscular septum that is arising from the ventricular wall, from the base of the heart, from the apex of the heart. You see, muscular septum will form a partition between right ventricle and left ventricle. So this will not be complete. There will be a foramen or a communication existing between right ventricle and left ventricle in the embryological phases. Even the foramen ovale is persistent in embryological phase during earlier development in the right atrium and left atrium. So now, when you come to some conditions, some clinical conditions with respect to heart, you might be hearing some patients telling that there is a hole in my heart, there are two holes in my heart, there are three holes in my heart. So what are those holes? What they are mentioning is nothing but the non-formation, non-closure of this foramen between interventricular between two and left ventricles, and non-closure of this foramen ovale, or failure of fusion of the septum primum with the endocardial cushions persisting, resulting in a condition called as ostium primum, or the septum secundum is not successfully formed, and that results in persistence of this foramen secundum, and that results to an ostium secundum. So, if all the three are open and all the three are communicating with the right to the left, like right atrium and left atrium, and right ventricle and left ventricle, then that is called as like three foramens or three holes. That's what the general people say. But as a basic medical science student, you should be aware that there is nothing but these are the structures that are like interventricular septum foramen defect, and this is interatrial septum foramen persistence results in that conditions. Okay. Now, generally, when you observe in an embryological phase with respect to the living phase, like what you will be observing here is like there won't be any air in the baby when the baby is in the amniotic sac of the mother. As the baby is swallowing amniotic fluid, this amniotic fluid also enters into respiratory tract of the baby. As there is amniotic fluid in the lungs, the alveoli are filled with amniotic fluid, and hence there will be very minimal, very less chance of gas filled in the lungs. So there won't be any gaseous exchange from the lungs to the heart as long as the baby is in the amniotic fluid or amniotic cavity. Once the baby is delivered into the external environment, once the clamping is initiated, and then the baby stops getting the oxygenated blood, and then that's when the baby starts artificially trying to inhale, and then that's when the amniotic fluid escapes from oral cavity, from nasal cavity, and also amniotic fluid escapes into lymphatics and capillaries in the lung tissue. That results in functioning of your respiratory system, and where your um, heart and lung establishment of circulation, which is pulmonary. Now, I would like to add ventricular septum. Generally, if you observe this interventricular septum, like in the initial phase, what you will be observing is, as I mentioned earlier, that in the right ventricle you have a truncus artery. In the right ventricle, you have pulmonary trunk that carries the blood to the lungs. And on the left ventricle, from the left ventricle, you have aorta, which carries blood from the left ventricle. So, literally, the pulmonary trunk and aorta, these both blood vessels are derived from a common structure which is called as Truncus Arteriosus. Generally, we give a name for an artery when it is when it is taking the blood from the heart to the other organs. So, literally, here the pulmonary trunk is taking the blood from the heart, from the right ventricle to the lungs, whereas the aorta is taking blood from the heart to the whole body. So literally, these are both are arteries, and then generally, the embryologically, the earlier structure that is going to form this structure is called as truncus arteriosus. And this truncus arteriosus is a common structure earlier before the fusion or the formation of successive interventricular septum. Once the truncus arteriosus is partitioned, generally this truncus arteriosus is partitioned by the formation of a spiral septum. Here you can see observe here the formation of the spiral septum. The spiral septum is organized in such a way that the right ventricle, you can observe here, the right ventricle is communicated through to form the pulmonary trunk, and then the left ventricle is communicated to drain into or to pump the blood into the aorta. You can see here denoted by blue arrows, that is deoxygenated blood, okay, and the red arrow oxygenated blood. So this formation of this spiral septum contributes a major closure of this interventricular septum. Generally, interventricular septum comprises of two components. One is the muscular part of the interventricular septum, and the second one is the membranous part of the interventricular septum. Generally, this membranous part of the interventricular septum and this spiral aortico-pulmonary septum, these are structures that are neural crystals. If there is a cells, then there will be defective formation of this aorticopulmonary septum that leads to the straight aorticopulmonary septum, which results in aorta opening into the right and pulmonary trunk opening into the left, or which is called as transposition of great vessels. So aorta, instead of being arising from the left ventricle, it will be arising from the right ventricle. And similarly, the pulmonary trunk being arising from the right ventricle, it will be arising from the left ventricle. So these are some variations, most common variations that we are expected. These are some common defects. This formation of these structural organization defects leads to major congenital heart anomalies. Generally, some congenital anomalies are expressed in the earlier phases. Some congenital anomalies, individuals get complications at the age of 35. It depends on the severity of the complications of the heart. Okay, if you observe here, so generally this is an inferior vena cava. This is the umbilical vein which is bringing oxygenated blood. Okay, from the placenta. You can observe here. From the placenta, it is bringing oxygenated blood, and then it enters into the right atrium, and from the right atrium through foramen ovale it is pumped into the left atrium and thereby left ventricle and thereby entering into the aorta. And you can also observe here a major structure. This particular structure that is connecting here is nothing but the pulmonary trunk is connected to the aorta. The structure that connects the pulmonary trunk and aorta is nothing but ductus arteriosus. This is called as ductus arteriosus. So this ductus arteriosus is going to communicate, share the blood of oxygenated blood that is received from the placenta into aorta. And the second source of shunting is the oxygenated blood shunts into the left side through foramen ovale. Okay, these are the two sources where the shunting of blood takes place, in resulting in pumping the oxygenated blood through aorta to the whole body. Generally, the foramen ovale gets closed once the blood returns from the pulmonary veins. Once the pulmonary trunk, once the baby is delivered and the pulmonary veins, like you have superior pulmonary, right pulmonary artery and a left pulmonary artery that takes blood from the deoxygenated blood from the pulmonary trunk. So once this blood enters into the lung, once the baby is delivered, then you see that the lung is getting the deoxygenated blood and the baby starts inhaling after delivery. So that's when the lung starts functioning and then it brings oxygenated blood through the superior and inferior pulmonary veins. Once this blood returns, if you observe here, so these veins were earlier blue in color because the arteries were taking deoxygenated blood and bringing deoxygenated blood back. Once the fetus starts breathing, then the lungs alveoli comprises of oxygen, and this oxygen stimulates the exchange of gases between the alveolar epithelium and the capillary, and then that results in bringing oxygenated blood. Once this oxygenated blood is returned, so there is a blood returned from the superior and with the more concentration. So that results in pressure generating on the septum secundum, resulting in closure of this foramen, which is foramen ovale. And similarly, this oxygenated blood, once there is an high oxygen content in the aorta compared to the pulmonary trunk, then automatically this ductus arteriosus also gets obliterated, resulting in formation of ligamentum arteriosum. Generally, there are some landmarks with respect to this ductus arteriosus. If you look at this ductus arteriosus, this is aorta. So, if there is any malformation in the aorta before the ductus arteriosus, we call it as pre-ductal condition. If it is after, then it is called as post-ductal. Generally, if you observe, I'm just giving you an introduction of different structures here. What are the possibilities? When we are discussing there, I just want you to pay focus on this particular aspect of this animatory video, which can be available even if you just type cardiovascular system development embryology in YouTube. You can get this animation video. Okay, so here you see this. This is the ductus arteriosus, which is transformed into ligamentum arteriosum once there is oxygen levels of the aorta are high compared to the pulmonary trunk oxygenated blood. So that automatically we clamp the umbilical vein, and thereby the oxygen level goes depletes in the right side, and then thereby this pumped blood will enter into the lungs through right and left pulmonary arteries. This is a brief introduction about how the heart functions, how the heart develops, how the heart starts take its action once it is being formed. Now I would like to, with this basic knowledge, now I would like to take you all. So generally, this was a study done, and in this study, it says that the distribution of patients according to congenital heart diseases. Generally, this study was were performed till the April 1997 to Jan 2017. And this is an article collected from this NCBI. Okay, this is a PubMed Index journal. Okay, so here it comes.
Sir, Dr. Abraham, sir, sorry for the interruption, sir. Can you just maximize your presentation, sir, to the full screen?
Yeah.
Thank you, sir.
Welcome. Okay, so if you look at this, you can see here, these are the major congenital anomalies that are associated with the defects. Okay, if you look at this, the defects with left to right shunt. So if you look at here, that is the left to right shunts, the number of cases are very high. Generally, the shunt, what is the term shunt refers to? As we have seen, because of the presence of these foramens, like foramen ovale, foramen primum, or foramen secundum, we expect these foramens to be communicated, and that is these foramens to be persistent. And as we all know, that pulmonary circulation has low pressure compared to the systemic circulation. Generally, the pulmonary circulation we see it on the right side, whereas systemic circulation we see it on the left side. Why there is high pressure compared with the right side to the left? If you compare, then you can see that on the right side, you will be seeing that the blood has to be pumped just to adjacent organs, that is lungs, and there is no gravity or nothing else. So it is less pressure is sufficient to pump the blood from the right chamber. Whereas onto the left side, you need the blood to be pumped up to your scalp. So that is the reason why it says that you need the pumping of the blood. So there is pressure is required. That is, like you all know, that the systolic blood pressure, diastolic blood pressure, all these basics you are aware, like 120, 80. Okay. So here, defects with the left to right shunt. what is the complication if there is a left to right shunt? The left has more pressure, and hence, generally, automatically, what happens is the shunting of blood will be taking place, and generally, in the left side, you will be seeing oxygenated blood, and hence, this oxygenated blood will be pumped and then mixed up with the uh, deoxygenated blood. And then you also see the complex heart. The second major condition that is you observe in this is complex heart defects with the tetralogy of Fallot. And this is a condition which is a tetralogy of Fallot. Generally, this is caused by the defective formation of the aortic-pulmonary septum mainly, and the complications are associated with it. How? Yeah, we'll try to discuss in detail if there is a possibility. Okay, then we also have obstructive heart defects. Sometimes there is atresias, there are some stenosis, like aortic stenosis, pulmonary stenosis. So these obstructive heart defects and also obstructive heart defects with shunt and some others. So these are this is the yeah. This is an ultrasound image of an heart. Position, like if you see the right ventricle, right atrium, left ventricle, and left atrium. Okay, this is how in an ultrasound you observe a 33-week four-chambered heart. You can see here. So these two are the right and left ventricles and the right and left atrium. Okay, generally they say that the cardiac anomalies are congenital anomalies of the heart are mainly associated from aneuploidy and also microdeletions. Generally, microdeletions are genetical conditions associated with um, chromosomal disorders. Like you have structural chromosomal aberrations and numerical chromosomal aberrations. If you see, this comes under structural chromosomal aberrations, where the chromosomal structure is altered and that results in microdeletions. Okay. If and aneuploidy, coming to aneuploidy is mainly because of the number of chromosomes. As you all know that um, uh, during the disjunction of chromosomes, there will be a failure of non-disjunction of chromosomes in the meiosis 1. That results in conditions like trisomies, okay, like or monosomies. Trisomies mainly like trisomy 13, trisomy 18, Edwards, trisomy 13, and then trisomy 21, Down syndrome. Okay, and then you have the monosomy, which is X0, that is Turner syndrome, and then you have an extra X, that is Klinefelter syndrome. Okay, and then you have a deletion, that is microdeletions, which is in DiGeorge syndrome. Okay, this is associated with your thymus, and then you also have the 7q1123, that is 23, that is deletion Williams-Durant syndrome. So if you observe what are these common congenital anomalies that you expect in this is like atrial septal defect. I hope now you understood what is atrial septal defect. Why I took you through the video in the first session is to give you an idea of what is atrial septal defect. So generally, what are the common foramens that we see in the atrial septal defect are like you have foramen primum, foramen secundum, and foramen ovale. If any of these foramens are persistent, that can lead to atrial septal defect. And then ventricular septal defect. If you see the most common ventricular septal defects that are observed is from the um, most common ventricular septal defects are observed from the membranous part of the ventricular septal defect. That is, the aortic-pulmonary septum comes down and fuses with the um, muscular part of the interventricular septum, and that results in failure. So that is the most common one, membranous part of the ventricular septal defect. And then the other one is PDA, patent ductus arteriosus. As you have seen that the persistence of ductus arteriosus, in spite of the baby delivered, so that leads to a condition which is called as patent ductus arteriosus. Okay, and then You have HLHS, which is hypoplastic left heart syndrome. So generally, the left heart should be hypertrophy, generally, normally, and there won't be any growth, any differentiation, any development. Muscle generally is grown when you work it out. Like if you go to gym, if you work out, if you lift loads, that leads to hypertrophy of your muscle. Similarly, the cardiac muscle. So here, the heart, there will be a condition which is called as hypoplastic left heart syndrome. Yeah, yeah. And then we have this percent with the congenital heart diseases, it is around 80% you expect in a trisomy 13. Okay, and these are some other associated clinical features which we don't consider for now. Okay, and then we have the second condition, which is a trisomy 18. This particular 18th chromosome of autosome has failed to non-disjunction, and that results in an extra 18th chromosome present on the other side. So this comprises of atrioseptal defect, ventricular septal defect, patent ductus arteriosus, and then you have the tetralogy of Fallot. Then you also have this double outlet right ventricle. So generally, what happens is in the right ventricle, you get two structures that are taking out double outlet right ventricle, and then you also have coarctation of aorta. Generally, this is a coarctation of aorta. If you see a blood vessel like large arteries like your aorta, what you are supposed to expect is in aorta you will be having all the layers. Kind of histologically, you should have knowledge or idea of what are the layers that are found in an elastic artery. Aorta is an elastic artery, large artery. Generally, in this aorta, we see tunica intima, tunica media, tunica adventitia. These are the layers. Generally, in the tunica intima, you see subendothelial layer also. And then after that, you see tunica media, which is bounded innerly by the inner elastic lamina, and then externally by the external elastic lamina. Generally, in the tunica media, you expect a lot of elastic fibers intertwined between the smooth muscle. So, if there is a defect in the formation of these elastic fibers and the smooth muscle, results in coarctation of the aorta, and that is called as coarctation of aorta. With respect to the site of formation of the ductus arteriosus, we call that as pre-ductal coarctation and post-ductal. So those are the two conditions that exist with respect to coarctation of aorta. Then you have bicuspid aortic valve. And generally, with the trisomy 18, you will be seeing 90 to 100% of the congenital heart diseases. Generally, we don't see the survivability of these two conditions will be very less. And then we see this trisomy 21, where the atrioseptal defect, ventricular septal defect, and then atrioventricular septal defects, and then tetralogy of Fallot, up to 40 to 50% are associated with the congenital heart diseases. Similarly, your Turner syndrome. Okay, so these are different conditions that we expect in the cardiac anomalies, mainly because of the aneuploidy and mainly because of the micro deletions, which is um, due to the chromosomal variations. Thank you. So, if you look at the classification of the congenital heart diseases, like we can say that there are two types, mainly acyanotic heart diseases, cyanotic heart disease. Generally, cyanotic heart diseases are where you see in the peripheral tissues of the body, like the tip of the nose and the nail beds and at the lips and in the mucosa, you will be seeing bluish discoloration. This is mainly because of the decreased pulmonary blood flow and mixed blood flow pumping to the body. And there are another conditions that is acyanotic heart diseases. This is because of the increased pulmonary blood flow. And as there is increased pulmonary blood flow, definitely oxygenated blood is being circulated, and hence we don't see the signs of cyanosis. And this will lead to obstruction of blood flow also. Okay, these are different congenital shunts. What are different congenital shunts we have here is left to right and right to left. Generally, when you observe the left to right, the ventricular septal defect is considered as left to right, and atrial septal defect is also considered as left to right, and even patent ductus arteriosus is considered as left to right. All these three cases, what you will be observing here is the ventricular septal defect will be contributing for the um, formation of the pumping of blood because of high atrial pressure, high ventricular pressure on the left side. So generally, the blood will be pumping from the left to the right. And if you observe with respect to the atrial septal defect, so you will be seeing that the atrial septal defect is leading the through the foramen ovale or foramen primum or foramen secundum leads the shunting of blood from the left to right. Similarly, the Ductus arteriosus, because of the high atrial pressure, so generally from the aorta, the oxygenated blood will be shunting into the patent ductus arteriosus. Then coming to the right to left shunts, the transposition of great vessels. As I was mentioning, if the aorticopulmonary septum is not formed spirally, if it is formed straight, that leads to transposition of great vessels. So literally the aorta will be on the right side and the pulmonary trunk will be on the left side. So then what happens with the transposition of great vessels if you observe? The aorta will bring the deoxygenated blood from all over the body, and then the same oxygenated blood will be the same deoxygenated blood that is supplied to the tissues will be again brought back into the mm, mm, same system. Okay, then we have the tetralogy of Fallot, where you see the four conditions like overriding of aorta, pulmonary stenosis, interventricular septal defect, and right ventricular hypertrophy. So these all are facilitating the right to left shift. Generally, if you observe all this right to left shift, if you observe truncus arteriosus, persistence of truncus arteriosus, where the pulmonary septum didn't fuse to form the interventricular septum, and that results in the pulmonary septum, a persistence of truncus arteriosus, and hence aorta and pulmonary trunk are not fused. And if you observe the truncus arteriosus, that is a structure that is giving rise to aorta and pulmonary trunk. And then you have tricuspid atresia. This is a condition where there will be atresia in the right side. Generally, tricuspid valve is found in the right side, and hence what you expect here is the tricuspid atresia will be formed at the plane of the right junction of right atrium and right ventricle. So there won't be shunting of blood from right atrium into right ventricle. Instead, the blood will be pumped or sent through the right foramen ovale, and hence persistent of foramen ovale in this case of congenital shunts. Okay, if you observe here, so this is about the ventricular septal defect. Only the ventricular septal defect is if you see here, this is the muscular part of the interventricular septum, and this is what is aorticopulmonary septum, and this is expected to fuse with this, forming membranous part of the ventricular septum, and there will be a defect in the fusion of this that results in membranous part of the interventricular septal defect. And then if you look here, so here you can observe this. So this is the interventricular septum, and there is a communication existing between the right ventricle and the left ventricle. And this is a membranous part of the interventricular septal defect. Then coming to the atrial septal defect. There are very few. That is more common ventricular septal defect, which is membranous ventricular septal defect, which you see, and the individuals are surviving. Okay, if you look at this atrial septal defect, it is found in one of 1500 live births. This is from the study from the BMJ journal, okay, British Medical Journal. Okay, so what is the atrial septal defect? Generally, it is a persistence of communication between right atrium and the left atrium. As I mentioned earlier in the video which I have shown you, I was showing you about the foramen ovale, foramen primum, foramen secundum. So the same, these foramens are persistent, and that leads to the presence of communication between the right and left, and that results in shunting of blood from right to left. Sorry, left to right, because the left has the higher atrial pressure. If you look at this is an interatrial septal defect, okay, for foramen ovale. So this image is collected from this British Medical Journal, practice on the 2017. Okay, 3.5 infants for this condition. Interatrial septal defect is a condition commonly existing around 3.5 infants per every 1,000 live births. Okay, coming to the next condition, which is patent ductus arteriosus. If you look at this patent ductus arteriosus, patent ductus arteriosus is nothing but a communication existing between the pulmonary trunk and the aorta. Okay. So it is 1 in 2,000 births, accounting for 5% to 10% of all congenital heart diseases. Okay. So this is collected from the study journal that is collected from the Journal of Pediatrics, Pharmacology Therapeutics. So in the year 2007, they performed a study with respect to the patent ductus arteriosus, where 1 in 2,000 births, accounting for 5% to 10% of all congenital heart diseases. Yeah. Now here comes the transposition of great results. As mentioned earlier, so the aorticopulmonary septum, the spiral formation, if it is a spirally formed aorticopulmonary septum, then that leads to the presence of aorta in the left ventricle and pulmonary trunk in the right ventricle. But as there is a defect in the migration of the neural crest cells, resulting in defective formation of this spiral aorticopulmonary septum, instead of being spiral, it becomes straight. Since it is straight, aorticopulmonary septum, so you see here that the aorticopulmonary septum is straight, and hence pulmonary artery will be opening in the left ventricle. So generally, what you expect in this circulation, if it is from the left ventricle? So generally, left ventricle, the blood is taken into the pulmonary artery, and then it goes into the um, pulmonary trunk, and then it goes into the right and left pulmonary arteries and reaches the lung, and then received blood into the left atrium in the form of superior pulmonary vein and pair of superior pulmonary veins and pair of inferior pulmonary veins. So generally, this again is bringing oxygenated blood, and again it is entering into left ventricle, and then again it is pumped to the lungs. So the pulmonary circulation exists within the left atrium and left ventricle. And if you look at this, so the superior vena cava and inferior vena cava will bring deoxygenated blood, and brings it into the right atrium, and then through the tricuspid wall, the blood enters into right ventricle and then enters into aorta, and then distribute throughout the body. And then again, superior vena cava and inferior vena cava brings the deoxygenated blood, and then again same. So in these conditions, the transposition of great vessels, persistence of this, as there is no oxygenated blood in the aorta compared to the pulmonary trunk, there won't be closure of this ductus arteriosus. So surgical corrections are essential for this kind of situation. So generally, the vessels will be switched and then stitched back. Okay. Or else there will be systemic circulation only going in the right side and pulmonary circulation alone going in the left side. And presence of these defects will facilitate the shunting of blood and thereby survival of the infant. As the infant grows, the oxygen demands will increase, and that leads to the complications. or signs. Yeah. This is a tetralogy of Fallot, which is a rarest condition, which is like the 3 of every 10,000 live births. Okay, so what are the defects? If you observe, the aorticopulmonary septum will not fuse with the muscular part of the interventricular septum. And this spiral aorticopulmonary septum, instead of being in the center, like it slightly slides towards the pulmonary trunk. That results in narrowing of the pulmonary trunk, and then aorta will be overriding the interventricular septum. So here literally overriding of aorta is a condition, and then second condition will be like stenosis of the pulmonary trunk, like if narrowing of the pulmonary trunk will be there. Okay, and then aorta is overriding here. Okay, you can see in addition, because there is a lot of blood pooled in the right ventricle, so the right ventricle has to pump more, so that results in hypertrophy of the right ventricle. The study is collected from this Journal of Rare Diseases, which is a tetralogy of Fallot. Okay, 3 of every 10,000 live births we expect tetralogy of Fallot. And this is another condition which is called as total anomalous pulmonary venous return. Generally we have the pulmonary venous return. We have the pulmonary veins bringing blood into the atrium. So we generally have superior pulmonary veins and inferior pulmonary veins, a pair, right and left. Okay, generally we have this total anomalous pulmonary veins. Supracardiac will be around 50% possibilities, and then cardiac will be around 20% possibilities, and infradiaphragmatic will be like 20%, and then mixed will be like 10% variance. So this is what you are going to see. This is generally normal, and you see here, this is the left atrium, and you see this is an accessory vein, that is pulmonary, total anomalous pulmonary venous return. Dear location, please stop asking for annotation. So you can see here, so pulmonary veins do not connect to the left atrium, so they directly connect into the pulmonary trunk. So there will be anomalies, like they won't be normal, they will be like abnormally connected. That is total anomalous in pulmonary venous return. And then this is about Truncus Arteriosus, as we have seen already that so this is a common artery. You see, aorta and pulmonary trunk are common. So here, up to here, the partitioning is there, and then there is no further partitioning. Actually, this is supposed to be formed in the form of a spiral septum. And this is called as persistent truncus arteriosus. Then this is another condition which is called as tricuspid atresia. If you look at this image, you have here the right and you have here the left. So left here containing the superior and inferior pulmonary veins, and this is the right. And if you see here, there is a partition. There is no communication between the right atrium and the right ventricle. And you see here, there is no closure of the interventricular septum. The membranous part is incomplete, and the muscular part is present, but the membranous part is incomplete. So generally, what happens? The blood will not shunt here. So literally, surgical correction is required, and tell that like how is the compensation managed in the presence of this ductus arteriosus and presence of this foramen ovale. All these conditions facilitate the survival of the baby. So you can see here there is absence of tricuspid wall. Instead, there is presence of atresia. Okay, the right atrium not connected with the right ventricle. And you also appreciate here the presence of ventricular septal defect. And as there is ventricular septal defect, so the blood from the left ventricle pulls into the right ventricle, and then from the right ventricle, the blood is pumped into the pulmonary trunk, and then again brought back into the right atrium through the superior and inferior pulmonary veins. Sorry. Left atrium, sorry, superior and inferior pulmonary veins. Generally into the right atrium, the superior vena cava and inferior vena cava and coronary sinus brings the blood into the right atrium. Okay, persistence of this foramen ovale will shunt the blood, and then that results in mixing of deoxygenated blood with the oxygenated blood. So now, if you look at this is nothing but the atrioventricular canal defects. So if you observe, this is interventricular septum, and this is atrioventricular canal defect. So right atrium with the right ventricle, left atrium with the left ventricle. So if there is any defect associated with the tricuspid valve, whether in the form of tricuspid atresia, or in the form of tricuspid stenosis, or in the form of on the left side bicuspid stenosis. So if you look at here, there is a possibility of pulmonary atresia also. This is another congenital anomaly associated with the ventricular septal defect. If you look here, there is a persistence of membranous ventricular septal defect, and there is an atresia of pulmonary artery, pulmonary trunk. Since the blood cannot enter into the lungs through this channel, so generally they establish an alternate circulation, and then they maintain the communication. Yeah. Similarly, similar to the pulmonary stenosis, we also have a condition with respect to the aorta, that is aortic stenosis. And now you see the left ventricle, the cavity, the chamber contains less, because this condition is a hypoplastic left ventricle. Generally, what you expect here in this is that the left ventricle contains low growth. Generally, we have the terms like hypoplasia, hyperplasia, hypotrophy, hypertrophy. Generally, hypoplasia is a term associated with the low growth of the cell proliferation, and thus result in underdeveloped left ventricle presence. Yeah. Now, if you look at this is normal aorta, and this is a communication between pulmonary trunk and aorta, which is in the form of ligamentum arteriosum or ductus arteriosus, which is transformed as ligamentum arteriosum. But here, if you observe, there will be coarctation or cut pinched aorta or narrow aorta or constricted aorta because of the non formation of the connective tissue like elastic fibers and the smooth muscles in the clinical media of the aorta. So generally, this coarctation of aorta can be either preductal coarctation or postductal coarctation. You can see if it is preductal coarctation, then the patent ductus arteriosus is found. If it is postductal coarctation, then the ductus arteriosus is obliterated. And hence, what do you experience? What are the signs you exhibit? What are the signs you see in the patients? Generally, in the coarctation of aorta, what you see is the subclavian and common carotid right and left, and then right and left subclavian arteries receive oxygenated blood with a higher pulse, whereas the femoral artery, the lower limb, if you feel the pulse of the lower limbs, then you see the pulse of the lower limb will be less compared to the upper limb. Okay, now with this, I would like to conclude my session. These are some congenital anomalies which we have gone over. Okay, if you have any questions, yeah, you are welcome to ask. Good morning to all my students who are currently faculty and other positions. Happy to see you also. Yeah.
Good morning, sir.
Sir, good morning, sir.
Sir, quality of tetralogy that happening at the time both problems happened. That operation I will do, sir. In overriding of aorta and ventricular septal defect and pulmonary stenosis and right ventricular hypertrophy. Those are the problems happen same time. But I will manage sir, that operation.
Sir, to be frank, I am an anatomist, sir. For your kind information, I am an anatomist, sir. Probably,
Okay.
maybe if you can, cardiothoracic surgeon, if you consult, maybe they will give you a better idea, sir.
Okay, sir. Okay, sir.
Yeah. Thank you very much, sir. Thank you for understanding.
Okay.
Thank you very much, Dr. Abraham, sir. The session was very informative, sir. Thank you very much. Sir, there are few questions being posted in the chat box.
Yeah, ma'am, sure. Yeah, when should you suspect that your child could be having a heart disease? Generally, we see that there is a score called as Apgar score, APGAR, in which you will be seeing for cyanosis. Okay, when you are seeing cyanosis, then you can check. How long can you live with congenital heart disease, and does it is sorry, it's moving. And is completely curable. Yeah, it depends on the type of the congenital heart disease. So, like if it is correction, then we can the cardiothoracic surgeons they can fix the issue.
Participants, if you have any other queries, you can post it in the chat box.
Is there any way that I can increase the chat box size? Because it's small and hence by the time I'm reading it, it is.
You can just scroll it up, or I can help you out with the questions, sir. I think there are no more queries, sir.
Thank you, ma'am.
There are a few
Thank you very much,
feedbacks
students,
coming.
for your kind patience and for your kind attention towards the lecture session. Thank you for participating in this conference.
Thank you very much, sir. Right?
Yes, ma'am.
Almost it's midnight now. Thank you so much, sir. Time and giving your lecture. Thank you very much, sir.
Yeah. Thank you very much. I appreciate it. Thank you.
This is to all.
ಟೀ ಕುಡ್ತಿರಕ್ಕ ಅದಕ್ಕೆ ஒரு நாள் மோர் குடிச்சிட்டு சளி குடிச்சிருச்சு
Thank you. I thank all the participants for participating in this session. Next session will be between 12 to 1 p.m. You would have received the mail for the next session. Please come to the next session at least 10 minutes before, around 11:50. Thank you all.